Hi there everybody and welcome. Thank you so much for joining me today. My name is Dave Fletcher. I'm the Director of Care at Catherine House Hospice and I also chair the Staffordshire and Stoke-on-Trent Clinical Improvement Group for Palliative and End-of-Life Care. I'm here today to present to you about end-of-life care planning and particularly to provide a supportive resource hopefully for paramedics and any other clinicians working out there delivering pre-hospital care to become more comfortable with working with end-of-life care plans. So, without any further ado, let's jump straight in. So I suppose the main introductory topic that I wanted to cover is why end-of-life care planning matters within paramedic practice. And the main reason for this is completely based in the stats, in addition to our morals, our ethics, and about what a good death actually looks like. If we look at the NHS Fingertips website, you can see here the percentage of deaths that occur in hospital across all ages. The latest data that we've got is in 2023, and we can see that 46.7% of patients within 2023 are currently dying in hospital. However, if we look at some of the evidence that indicates how many patients would like to die at home, you can see that that is up to 81%. So again, looking at the statistics, it is very likely that a proportion of the 47% of patients that died at hospital did not wish to die there. They would have preferred to have died at home, surrounded by their loved ones in a comfortable environment. So firstly, as paramedics, we have an obligation to do the very best for our patients, and that means aligning with preferred place of care and preferred place of death wishes. And we know that care planning is a vital way to do that. For us within pre-hospital care, it matters even more given this report here, which was published by the strategy unit looking at activity across Staffordshire and Stoke-on-Trent, shows that patients in the last 2 years of life are 86% likely of needing an emergency admission, but are 90% likely to require an A&E attendance. And we know that a significant number of A&E attendances take place via the ambulance service. So the statistics are absolutely compelling, and it demonstrates that a key point where we can move the dial to keeping patients at home is by confidently applying end-of-life care planning within pre-hospital care. So that ticks the home-based care box and the person-centred care box. But plans do need to be clear. So the main tools, I suppose, that as clinicians we have at our disposal at capturing those patient wishes are respect and DNA CPR. In addition to a range of other care plans that we will go through a little bit later on. I'm mindful that perhaps the space of this bubble here where my face currently is blocking a couple of the slides. I apologise for that. But you can see here that locally the latest data indicate that at least 14 palliative and end-of-life care patients are admitted at Royal Stoke every day. And the average cost to the health system for each admission is about £7,500. So it's absolutely vital for all involved. And making these decisions within pre-hospital care absolutely is not easy. I'm speaking here from experience myself. A job that comes to mind is being 4 o'clock in the morning. There's a patient who has had some indication of care planning, but we're not entirely sure how much. And making that decision in isolation can be a very worrying and a very scary place. And so it's not unsurprising that we get some of these concerns and anxieties from paramedics. What if there's a conflict between the patient and their relatives? What happens if something goes wrong after I've made my decision? Am I likely to be blamed? Will I lose my registration and therefore my livelihood if I do something that could be potentially quite risky? And equally, having these kinds of conversations in the settings that we find ourselves in that are often very time constrained and can escalate very, very quickly, these are very, very difficult things to do. And because of those things, there are several myths that take place within palliative and end-of-life care that is worthwhile us talking through. So the first myth there is acting on respect or DNAR plans is always more riskier than conveying. That absolutely isn't true, and some of the instances that we'll go through a little bit later will share the reasons why. That any complaint or challenge on your decision making will automatically threaten your registration. Again, that is not accurate. That it is safer to ignore the plan and to treat as normal. There is several laws that are there that make that absolutely inaccurate. And then finally, if there's a disagreement, I must convey to protect myself. Again, something similar before. So what is the reality? Well, the reality is following a clear plan with a documented rationale, regardless of the outcome, is usually more defensible and more safe for your practice, but equally the right thing to do. Our regulator, the HCPC, looks whether decisions were reasonable, proportionate and well documented. And the HCPC covers a lot and shares a lot of their process on their website. I'd invite you all to go and have a look at that. Care against documented wishes can lead to complaints and scrutiny. It can. This is a very tough time for families and for the friends of people that have died. So there may be an ask for you to justify your decision making, and that should be absolutely okay to do so as long as we've done everything correctly. And then finally, senior advice, clear communication and good records often provide a safer route. So what is it that we're all striving for? And I've never met a paramedic that doesn't want to do a very good job for their patient. So what does that look like within palliative and end-of-life care? Well, firstly, best practice looks like finding and reviewing any type of evidence or information that supports the patient's wishes surrounding their palliative condition. That might be included in respect plans, DNA CPRs, advanced directives, any type of electronic records, any engagement with hospices. So that's step one. Step two is to assess the person. So what's their current condition? What's the trajectory? What's the reversibility? Does the situation that we presented here today match with the plan? If it doesn't, what are those differences? The third area then is to consider capacity. So to make the decision about the patient, and particularly about treatment and conveyance, we need to consider if the patient has capacity. That will provide two very different pathways depending on the outcome of that question. Step four is to align our actions. So if the plan and the clinical picture should align, we can then focus on symptom control and comfort, which is ultimately what all palliative and end-of-life care clinicians are striving for. Step five then is to communicate clearly with all the stakeholders. That includes the patient, if they have capacity, and even if they don't, to see what level of communication the patient has, with relatives that are on scene, and we will see how engaging with relatives is a requirement, absolutely. But then, of course, with other staff or any other healthcare professionals too. And then finally, to document your reasoning. Documentation is going to be a theme with this presentation that we will go through several times, and I'm not going to offer any apologies for that, because if it wasn't written down, it could be argued not to have happened. So how do we minimise the risk whilst respecting care plans? Well, later on in the presentation, we're going to go through a step-by-step guide that I would suggest would be absolutely supportive of very safe and effective practice. If you follow the step-by-step process that we share later on today, it is very unlikely that you will come to any professional detriment because of your actions. But what we want to do is we want to seek and use senior clinical advice where we can. We want to check our understanding throughout and avoid any misunderstandings. We want to record the discussions. We want to justify any deviations, because we know things aren't always black or white. They aren't always inside of scope or outside of scope. And we want to complete that documentation. Again, I'll make no apologies for keep on reiterating that point. So let's start to have a look at some of the governance then that informs our practice surrounding end-of-life care planning, because if we align with the governance, the likelihood is everything is going to be okay for you as the professional and for the patient, both of which are incredibly important. So let's have a look at the core legal framework that informs our clinical practice surrounding end-of-life care planning. The first major piece of legislation is the Mental Capacity Act, which was passed in 2005. As paramedics, we're very experienced at being able to apply this act within the pre-hospital space. So assessing the patient's capacity based on their level of consciousness at that time, and in addition to anything else that may have. It is the main law for adults who may lack capacity in England and Wales. It sets the 5 key principles that we all know of. We should always presume capacity. We should support the patient's decision. We should allow unwise decisions as long as they have capacity. We should act in the best interests of the patient, and we should use the least restrictive option. It is that act that also provides that legal test for capacity that we do have to apply pretty much on a shift-by-shift basis. The second piece of legislation then is the Human Rights Act. Now, this is the act that brings the fundamental rights of patients into UK law. That includes the right to life, freedom from degrading treatment, respect for private and a family life. So it's this act that can be a little bit at conflict at times to some paramedics. On one hand, we're saying everybody has that right to life, and we're very, very concerned about suggesting not intervening. However, it is also the act that says we must respect private and family life, and if those are the wishes of the patient, we should be honouring them as well. Those decisions surrounding DNARs and similar plans engage Article 8, which is that autonomy and bodily integrity part of the act. They must be respected because that is a person's human rights, and we should be respecting their dignity also. Again, we know about this, but let's just cover it in a little bit of detail. The key principles for paramedics: we should always presume capacity unless there is clear evidence to the contrary. That is always your starting point for every interaction. And on the whole, in practice, I think we're pretty good at doing this. Point 2, best interest. So if the patient's capacity is lacking, we must be acting in that person's best interests, not what feels safest for me. We should be considering the patient's wishes, values and beliefs. Now, we know at times that can come into conflict with the relatives' wishes, and they are very, very important, and we'll look why in a minute. But the key thing here is to act in the patient's best interest to be compliant with the Mental Capacity Act. The third point then is the duty to consult, and under the Mental Capacity Act of Section 4, we have an obligation to consult family members and others involved in the patient's care where practicable. Their insights are absolutely vital to understanding the best interests for that patient. Now, the key phrase here is where practicable, because we know as paramedics that we don't always have the luxury of time in those time-critical conditions when we are needing to choose to start resus or not to. That is where we can often, again, feel that we are in conflict with some of the points of these acts and these pieces of legislation. And those things are changing and variable, so there isn't necessarily a black and white answer. If you have the time and it is reasonable to engage with those family members, we should do so. If we can't, then we should be documenting the reasons why we can't, and we should be reasonably comfortable to be able to do that. Point 4, which is very important, is advanced decisions then. So advanced decisions to refuse treatments are legally binding if they are valid and applicable. And it's a key point here when we're talking about the legislation, is that attempting CPR against a valid ADRT, which is a legal document, would be considered a lawful battery. So in terms of a document, stage 1 here is if there is an ADRT, we must absolutely see what it says, we must fully understand it, and we must abide by it. Now again, I know that there's a little bit of anxiety about the validity about ADRTs, and we'll cover that in a couple of slides' time. But it is a key legislative consideration. If there is an ADRT there, which is a legally binding document, it absolutely has to be followed. We'll just spend a minute then going through the Human Rights Act, the rights and the key cases. So Article 2 indicates that there is a right to life. We must act compatibly with the fundamental right to life, whilst recognising that preserving life at all costs may conflict with the other rights. And then we have to balance those rights, and we have to make a judgment call. Article 3 is freedom from inhumane treatment, and that protects patients from degrading treatment, including futile interventions that cause suffering without benefit. And then finally, we've got the right to a private and a family life. So this is where patient autonomy and bodily integrity must be respected, and that including families in DNAR decisions. So let's look briefly at a couple of the cases that are really important to palliative and end-of-life care, where some of these articles within the Human Rights Act have been tested. So we've got the Tracy case, and that case established a strong duty to consult capacitated patients about DNA CPR, unless engaging with them would cause actual harm. There has to be a strong presumption of involvement in decisions about one's own care if the patient has the ability to do so. And then the second case of note is the Winspear case. And here it was confirmed that the duty to consult the family and others for patients lacking capacity should be taken there where practicable. Failures to consult can breach Article 8 of those rights to private and family life. So the couple of key parts there is when the patient is lacking capacity, and the second part is where practicable, which we spoke about a little bit earlier. So we touched upon this briefly, but let's spend a bit more detail about it now. Respect plans and DNARs using the plans on scene. Now, they are different from ADRTs that we mentioned before. ADRTs are a legally binding document, whereas respect plans and DNARs are classified as evidence of the patient's wishes that was made at a specific point in time. So what we should do first is understand the document that is in front of us. Respect is a process form which summarises recommendations for emergency care when the person cannot decide or communicate. They capture contemporaneous clinical recommendations and documented preferences. So in terms of capturing the patient's wishes at that time, they're a wonderful resource because we very clearly know in an emergency situation, this is what the patient is indicating they would like to do. The second part then is actively search. So you are expected as part of your role as pre-hospital care clinicians to actively look for respect forms at home, if they're in care homes, if they're in a normal domiciliary location, or anywhere else where they're spending that time at the moment. I know personally how difficult it can be to hunt for respect documents, especially when time is of the essence. But I would invite you all to contact your local hospice or the hospice advice line if you absolutely need to, if you are thinking that there may be an end-of-life care plan on scene, but you're struggling to find it. If it is there, if it is on the digital respect platform, then that is something that the hospice advice line can share with you, and I'll share the number of that advice line at the end of this presentation. Step 3 then is to interpret what's on the DNAR, and again, I am familiar with the experience of having a fantastic, tremendous amount of relief to have found the document and then it is not legible, or the information on that document is incredibly lean. The DNA CPR is a clinical decision that CPR should not be attempted in a cardiac arrest. And a properly completed DNAR is strong evidence that not starting CPR is consistent with the Mental Capacity Act and the Human Rights Act. It isn't 100%, but again, in terms of weighing up all the information that you have available to you, it is pretty strong that supports an action of that type. And then step 4, when you've understood, when you've actively searched, when you interpret all those documents, document the reasoning. Now, again, my student days come from a time where it was try to write as little as possible because it gives you as much flexibility should you need it. That absolutely isn't the case here, and thankfully, I think that's a behaviour of times gone by. If you can document your rationale and your justification for making your decisions, as long as you have not been negligent in that decision-making process, then you should be absolutely okay. The HCPC adopt very much an approach to lifelong learning, and they recognise that we make mistakes. The challenges do come if we are not supporting that principle of lifelong learning, or if we're trying to hide things when things don't go right. So what's the difference between the ADRT and other end-of-life plans? We mentioned it briefly before. The ADRT is a legally binding document. It is made by a patient who has the capacity to refuse specific treatments. If they then lose capacity later, it continues to be legally binding. In terms of the validity of ADRTs, they must be written, they must be signed, and they must have a witness present. All that must be documented on the form. It must state that the plan applies even if the patient's life is at risk, and just to make it absolutely clear, treating against that document is completely unlawful. How that compares to other local end-of-life care plans, so there are a range of other plans. This includes treatment escalation plans, emergency healthcare plans, hospice plans. They aren't in themselves legally binding, but they do provide rich and valuable evidence to support your clinical decision making. So some of the other frameworks or documents that are incredibly important that contribute towards your decision making whilst using end-of-life care plans. First one is your regulatory requirements, so the HCPC Standards of Conduct, Performance and Ethics. I'm not going to talk too much about this. You will all know about this document. We all sign and agree to follow the behaviours within this document when we renew or when we apply for registration in the first place. And we should always be demonstrating our proficiency within our area of practice as well. Again, I'm not going to go through this. You all demonstrated this when you passed whatever course led to your reward of your professional registration. But as long as we abide by those behaviours, again, we wouldn't be breaching any regulatory challenges from our professional body on that note. So I mentioned before about this framework, a step-by-step guide that if we follow should lead you the majority of the time to the right output. So what is that? Well, firstly, let's arrive on scene. If you think this patient is palliative, let's look for and interpret any type of plan that is there. If that is a RESPECT, if it's a DNAR, if it's an ADRT, if it's a treatment escalation plan. This is all about evidence gathering, and as paramedics, we are fantastic at doing this as soon as we enter the scene. We often do it by visual or by audible, but now we're looking for hard treatment plans that can help us on our initial and secondaries assessment. As part of the next stage then, let's assess the capacity of the patient, because if the patient has capacity first, we are obliged to follow their wishes with all the necessary caveats. If the patient doesn't have capacity, however, it is then our responsibility to decide what is in that patient's best interests, using the clinical picture that's in front of you, but also the information that is included within those plans earlier, apart from the ADRT, which we have to follow because it is that legally binding document. Step 3 is within that process, consult where practicable, involve the patient, include those relatives that are close to them to make sure we align with the Mental Capacity Act section 4. The key part there is where practicable. If this is a time critical situation, you don't have the time to be able to engage with the family. But there may be some views or thoughts from the family that are included within those RESPECT plans, within the DNARs or the treatment escalation plans, so we should be considering those. Step 4 is align with the plans and the clinical picture. So consider whether not starting CPR, not conveying or not escalating fits the documented goals of care and the current clinical situation. Does all the evidence indicate, if the patient doesn't have capacity, that doing action that you're thinking of doing is in the patient's best interests? And again, that's not necessarily what you would do, it is what we understand that the patient would like at that time. Step 5 then is seeking advice when unsure. So part of the challenges of being a paramedic is the level of autonomy that we have to demonstrate in making these decisions. However, there is a plethora of support that is available to you. Locally, the ambulance service you work for should have a route of escalation that you can seek advice. In this instance, palliative and end-of-life care, you have an advice line available within Staffordshire and Stoke-on-Trent that is available 24/7. That is staffed by advanced practitioners, and they can help go through these types of scenarios with you as well. This is their day-to-day bread and butter. They're incredibly good at it. They're incredibly supportive. And they would absolutely value your call. And then finally, document everything like we said before. Talk about, capture the considerations when you were assessing capacity, think about the consultations, talk about the plans, the advice that you received and the rationale for making your decision. in all of the interactions I've had, either in complaint processes or regulatory investigations or civil cases that have been brought, if you can demonstrate that your assessment and your thought process was reasonable, if you can assess that, or you could argue that that is what the majority of your professional cohort would have done, exactly the same thing or something very, very similar, then that is a defensible position. And ultimately, we don't want to get into a position where we've done anything wrong that could harm our patient. Nobody wants that. So the key take-home messages, and thank you so much for your time and engaging with this session today. So the key take-home message is legal frameworks matter. The things that we've talked about today, the Mental Capacity Act, the Human Rights Act, our HCPC regulatory standards, they matter. And if you know them well and you apply them, the chances are, more likely than not, everything is going to be okay. Always presume capacity and respect autonomy. If the patient has capacity, then we must engage with them to ask what is it that a good outcome looks for you today, even if that doesn't align to what our own views are. If they don't, then it is your obligation to work in the best interests of that patient, including the engagement with their family and the relatives as well. Treat plans as crucial evidence. So respect plans, DNARs and treatment escalation plans are rich sources of evidence where the patient has taken the time to share with you, for this instance, what it is that they would like to do. Ignoring them without good reason is very, very hard to defend professionally or legally. But particularly, ADRTs are legally binding documents. And so therefore, working against an active ADRT without very, very, very good reason is absolutely against the law. And that is the final message. Please, please, please follow the valid ADRTs. And to bore you for one final and last time, good governance lives in your record keeping. Take the time to take clear contemporaneous notes that demonstrate your reasoning, your consultations, and your alignment and your knowledge of those legal and professional standards. Explain what you did, why you did it, and how it matched the Mental Capacity Act, Human Rights Act, and the HCPC standards. Our role is so complex and so dynamic. Nobody expects us to get it right absolutely 100% of the time. But the public and everybody has a reasonable expectation that we would not do our role negligently. And if you follow this step, you absolutely would not be practicing. And so finally from me, I did say that I would share the details of the palliative and end-of-life care advice line. So this number will get you through to a specialist palliative and end-of-life care specialist 24 hours a day, 7 days a week. And they are contactable on 0300 561 2900. They accept calls from patients, relatives, friends of patients, and healthcare professionals, and they can give you advice about any type of question that you may have about palliative and end-of-life care. Please do use it. It is our absolute pleasure to support you, and that's exactly one of the reasons why this service is here. The second thing I wanted to share with you is if you do go to a patient who is palliative but hasn't engaged with their local hospice services, please do consider referring them to us. Obviously seek their consent in the first instance, but we absolutely welcome referrals from paramedics. Hospices aren't just a place to go where patients die. We have a range and a plethora of service right from the point of palliative diagnosis that enables the patient to make the best out of the time that they have left, which includes preparing for symptom management, but also about how to live well throughout their palliative diagnosis. So please do consider those referral options. How to make a referral is available on every single one of our websites. That just leaves me to say thank you so much for the time for looking at this presentation. If anybody has got any further details or questions or would like to learn more about palliative and end-of-life care in Staffordshire and Stoke-on-Trent, please do reach out. My email address is david.fletcher15@nhs.net, or you can contact me via LinkedIn. I'm available there as David Fletcher. Thanks all. Take care.